Hi students, welcome back. We are now going to do the INICET exam questions which came in May 2022, and as usual they really got the Jimmy out of me this time, because the kind of question they asked, it was very evident that they want to make sure that each one of you is a MD in all the 19 subjects, and then you write a MD entrance exam. Yes, they were a little tough, and rightfully so, because I think if they want to make a choice, then the only way out is to make the questions tougher as every year comes. So yes, there was a lot of imprint of the JIPMER style of questions, and of course a lot of PJ Chandigarh type of questions, and rightfully so. It is the exam for the Institute of National Importance. Right, we'll try to solve the queries as you people can send me while we are doing the discussions, and yes, we are also available on the Prep Ladder forum for the discussions. So we'll start right away with the MCQs. Question number 1. On investigating for infertility, the male partner was found to have hypogonadotropic hypogonadism. How many of the following are associated with this condition? Now, when we say hypogonadotropic hypogonadism, it's very simple. When we're talking of the hypothalamus, which acts on the pituitary, and pituitary will make the FSH and will make the LH, which will act on the gonads, whether it's the ovary or the testes. In this case, it is the testes, and when we're talking about hypogonadotropic hypogonadism, that means the gonadotropins are not made. So this LH and FSH, these are the gonadotropins. See, hypothalamus acts on the pituitary by the gonadotropin releasing hormone. So gonadotropin releasing hormone will release the gonadotropins. So when the FSH and LH, which are the gonadotropins, are not present, we say hypogonadotropin, hypogonadotropic hypogonadism. That means since there are no gonadotropins, the gonad is not working, hypogonadism, right? So when there are no gonadotropins, it's very obvious that the FSH and LH will be low. So low LH and low FSH makes sense here immediately. Now we are talking of a male. When there is no FSH and there is no LH, there is no stimulation to the testes, and the testes obviously won't make testosterone and won't make the sperms. So there will be azoospermia and oligospermia, low testosterone. Obviously there is no relation of prolactin here. In fact, if at all, there will be a high prolactin which can cause a inhibition of the GnRH, isn't it? So low prolactin is obviously not the answer here, and low LH and high FSH also not an answer. So which one of these three are correct? So I would go with A, then B, and then with D. So A, B, D would be my correct answers for these questions. Now let's see a little bit about azoospermia, because azoospermia keeps coming in exams. So azoospermia is no sperms in the ejaculate. Aspermia is no ejaculate, that is no fluid comes out when the man has an intercourse, and azoospermia means there is an ejaculum but there is no sperms in it. So when there is azoospermia, it could be pre-testicular azoospermia, that is before the testes, the mechanism is not working. So low LH and low FSH, although the testes are normal. So that is a typical Calvan syndrome and the pituitary tumors. Now, what is testicular azoospermia? That means the testes is not made properly, or there is a gonadal dysgenesis, whatever is the reason. Because of some reason the testicular tissues have not been formed, so not formed properly, they are not working, so FSH will be obviously high. So this is what is the classical Klinefelter syndrome. One of the most common causes of testicular causes of azoospermia is the Klinefelter syndrome. Then Y chromosome deletions, we'll discuss a little bit about this also today. Immotole-Cilia syndrome, cryptorchidism, varicocele. Now cryptorchidism, what happens? If there are undescended testes, the testes are inside the abdomen, and when they're inside the abdomen, the testicular temperature approaches the core body temperature. So testes are happiest when they are 2 degrees less than the body temperature. That's why the testes are outside in a sac. So the testicular temperature is best 35, 35.5 for spermatogenesis, and if the testes are undescended, then the testicular tissues don't work well. So that could also be a cause of testicular azoospermia. Varicoceles, heat, chemotherapy, radiation are all reasons which can cause a person to have azoospermia. Now, post-testicular azoospermia is the easiest one to treat, because yes, there is azoospermia, but this is probably because of a block. So this is what we are very happy to take care of, because in this there might be a block in the vas. So the vas which is taking the sperms, if they are blocked here, what I can do is I can put a needle directly into the testes or into the epididymis, and take out the sperms and do a intracytoplasmic sperm injection. So when there is a post-testicular azoospermia, it is because of a block. There will be a normal FSH and LH. Right. So I would just want to tell you that when there's a person with azoospermia, I would always do a genetic testing, including karyotype analysis and a Y chromosome microdeletion assay. So the chromosomal defects, like just now I told you, the numeric chromosomal defects could be the Klinefelter syndrome, and Klinefelter syndrome is the most common chromosomal abnormality which causes azoospermia. Okay, so it is 2/3 of the infertility associated chromosomal abnormalities. Now, what is Y chromosome microdeletion? Now, this has been not asked in your exams, as of now, but then I'm very sure that it's going to find its way very soon into your exams. So, Y chromosome, as you know, is the chromosome which is going to determine the sex of the fetus. So, we know that Y chromosome has the sex determining region. So, that is on the short arm of the Y chromosome here. SRY, sex determining region Y. Now the long arm of the Y chromosome, this one will have the genes for spermatogenesis, and now this spermatogenesis genes which are present on the long arm of the Y chromosome, there can be microdeletions. Now those microdeletions also affect the spermatogenesis. Now the three types of microdeletions are the azoospermia factor A, B and C. Now A, B and C, out of which please remember the C is the most common type of microdeletion and has the mildest type of effects on spermatogenesis, and B is the most severe type of microdeletion and no sperms are generally found in this. So the most common one, which microdeletion is the most common? Azoospermia factor C, and which is the one which is not going to give any sperms, the most severe type is the azoospermia factor B. So I think some information is pertinent, keeping the style of questions which are coming in INICET. Some of these questions they make very simple so that all of you get some confidence of writing the exam. But suddenly they'll ask you a question which is getting a little complicated. So we'll see another question. Which of the following is not a criteria for preterm labor? Preterm labor, as you know, is anything, any delivery delivering before 37 weeks. The one which is delivering after 34 weeks and before 37 weeks is not a major problem. But the ones which are delivering before 34 weeks, when the lung is not mature, those are the ones which we really need to look very seriously. So cervix should be more than 1 centimeter dilated. Yes, there should be 8 contractions in 60 minutes with cervical changes, correct, and more than 80% cervix should be effaced, yes, and cervix should be directed posteriorly. So this is a spelling problem here, posteriorly, right. So what happens when a person is going to labor? We know that the uterus, if we see, so the answer to this question is obviously D, first of all, because the cervix should be always anterior when a woman is going to labor. We know that from Bishop's score also. If the cervix is posterior, it's not a favorable cervix. Cervix in the middle, then it is favorable, and very favorable is the cervix which is anterior. So let me try and explain you with a hand-drawn diagram. When we see the uterus, it is having a cervix which is downwards and forwards like this. But as the pregnancy comes into this, the uterus starts becoming bigger and bigger, and now this big uterus will have a cervix which will be upwards during the time of delivery. It will be like this. So this uterus gets retroverted and the cervix goes upwards. So see, this cervix is now in the anterior part of the vagina. So if the cervix is anterior, then we know that the cervix is about to open. It's come in the line of the uterus, and the uterus will now go into labor and push the baby out from this cervix, which is now favorable. So anterior cervix is what is a patient who's going to labor. But now the question here is showing the cervix is posterior, then that patient is not in preterm labor according to this. So which of the following is not a criteria? A posterior cervix is not a criteria, rest all is correct. We can also revise the Bishop's score a little bit for us to get into perspective once more. That cervix will have four criteria of the cervix we keep in Bishop's, and one is of the station, that the dilatation of the cervix, effacement, consistency, position of the cervix. If the cervix is anterior and the cervix is soft, cervix is well effaced and it is dilated, then it's a good cervix for delivery. That is a Bishop's score which is generally more than 9. More than 9 Bishop's score is favorable for delivery. Anything less than 5 is not very good. So that is the Bishop's score, and this again we are showing a anterior cervix. See, an anterior portion of the cervix is favorable. It gets more marks. Now, one more thing I wanted to remind you about the Bishop score is that when there is effacement, it is also now called as the length of the cervix. So, we remember effacement as 0 to 30, 40 to 50, 60 to 70, more than 80. That's the way of assessing the effacement, and percentages is what you people should remember. Although we also say effacement in the terms of length. See, basically it's the cervix getting taken up into the uterus. I always show you with my hand that if the cervix is getting effaced like this, if it is taken up into the uterus, then the cervix is actually becoming short. So you can say it is effaced 50, 60, 70%, or you can say that the cervix is becoming shorter and shorter. It means the same thing. But nomenclature wise, recent trend of exams I've seen in the NEET PG exam and also in the MCI exam, that they're asking you the percentage of effacement. So we'll remember the percentage effacement and we'll try not to waste much time on remembering the cervical length. Okay, so effacement is the better way of telling that the cervix is becoming shorter. Okay, so more about the preterm labor. So we say at least 4 contraction in 20 minutes and 8 contraction in 60, which was mentioned in the questions. So that is correct. On per vaginal examination, the cervix should be more than 1 centimeter dilated and more than 80% effaced. Now, if the cervix is more than 1 but less than 3 centimeters, we say it's early preterm labor, and if it is more than 3 centimeters, we say it is advanced preterm labor. Basically, what is the meaning of these last two statements? If the cervix is less than 3, less than equal to 3 also, you can say she is in latent phase of labor, and if it is more than 4 centimeters, then it is an active phase of labor. So latent phase and active phase can also happen at 32 weeks. It's basically the stage of labor, isn't it? So if the cervix is less than 3, she's in the latent phase, and if she's more than 4, then she's in the active phase. And we know that if the patient is in the latent phase of labor while in preterm, that is, she's 32 weeks and she's 2 centimeters, my tocolytics drugs will work. But if the patient is, let's say, 6 centimeters and has come with active labor with strong contractions, whatever tocolytics drugs I give, they will not work. That is advanced preterm labor. All right. So that's the reason why this distinction was shown to you. Right. So there's also something always keep coming about the prediction of preterm labor. I thought might as well sneak that part of information once more for you all. So prediction of preterm labor, that if you have a cervix which is much shorter in a patient's ultrasound at around 12 to 13 weeks, less than 2.5 centimeters, that will predict preterm labor. Also, if the funneling of the cervix is happening, if you see that if it is this is the bag of membranes and this is the cervix, which is in if you see, this is the cervix here. Now the cervix here is showing a T-shaped internal os and the external os channel, which we say it is in a T shape. Now if this cervix is beginning to open, it will start beginning to open from inside outwards. Inside outwards it starts opening. So first the cervix will start becoming a Y-shaped, then it will become a V-shaped, and finally it become a U-shaped cervix. And when we see on ultrasound that the cervix has funneled from inside outwards in a U shape, she is just about to deliver. So based on this alphabets also, they ask you questions sometimes just to trouble you, I'm sure, that which type of alphabet, if seen on the ultrasound suggesting funneling, is the worst alphabet suggesting preterm labor. You know, it's the worst situation alphabet like that they ask you sometimes. So when it is a U-shaped, she's just about to deliver. When it is a Y-shaped, she's just starting to funneling of the membranes into the cervix. Right. Which of the coagulation factor decreases in pregnancy? Now, coagulation factors are always increasing in pregnancy. Remember one thing, in pregnancy, we have a good coagulable state. A woman who is pregnant better be in a good coagulable state, in a hypercoagulable state. Why? Because she's going to deliver and she's going to have a placenta separating and the base of the placenta is going to pour. So the nature has decided that increase the clotting factors so that she's going to limit her blood loss at the time of delivery. So it's good to have a hypercoagulable state. So all the factors increase except, yes, 11 and 13. They don't increase. And there's something about the fibrinogen which I'm mentioning here. There's the slide actually which is, in our Prep Ladder forum, you must have seen on the app that in the physiology of pregnancy chapter, we've given you this slide that fibrinogen is increasing in pregnancy to add to the hypercoagulable state. So it increases almost 50%. So these are all the clotting factors, and you know that the 11 and 13. The plasma thermoplastin antecedent and the fibrin stabilizing factor, these two are reduced. Rest all are increased in pregnancy. Question number 4. Which of the following is more commonly associated with Kallmann syndrome? Now, Kallmann syndrome is hypogonadotropic hypogonadism. We know that the mediobasal nucleus or the arcuate nucleus is going to release the GnRH. Also associated is the migration of neurons of the olfactory placode from here. So, if there is hypogonadotropic hypogonadism with anosmia, they could be associated sometimes. So, that is what is classically the Kallmann syndrome, can be seen both in men and women, and it is associated with a delayed puberty rather than precocious puberty. So, this is not correct. It is not associated with the white forelock. White forelock, rare kind of a syndrome, which is known as a Waardenburg syndrome, and in that there could be some amount of hearing loss and some pigmentation defects along with a band of white hair in front of the head. So, that is also not seen here. Yes, anosmia is the most common association, that is correct. The answer is B. Syndactyly is also seen, but not the major association. Anosmia is the major association. So, yes, Kallmann syndrome has the KAL1 gene mutation, you know that well. It's got primary amenorrhea associated with the hypogonadotropic hypogonadism, and there's an insufficient pulsatile release of LH and FSH, and both males and females with Kallmann syndrome present with delayed growth and delayed sexual development. And patient with the disorder may also have family history of delayed puberty, cleft lip of palate, urogenital tract anomalies, and syndactyly. So, I hope you can see that it's written in green here. So, maybe it's not seen. Syndactyly was the last one, and delayed puberty, not early puberty. All right. Which of the following constitutes the modified biophysical profile? Now, modified biophysical profile, easy question they gave you this time, because biophysical profile has 5 components. You know, it has got the NST along with the ultrasound components of fetal movement, fetal breathing, fetal tone, and the amniotic fluid index. Now, biophysical profile which is modified and easier to do, because a biophysical profile done properly takes almost 30 minutes to 1 hour sometimes. So, something which can be done fast and equally reliable is a modified biophysical profile, which needs only the non-stress test and the amniotic fluid index. So, yes, all of you know that well, AFI plus NST. Now, abbreviated biophysical profile requires 10 minutes to perform, and superb antepartum surveillance method, because there was no associated unexpected deaths and deaths of the fetus, and modified biophysical profile is as predictive of well-being as other approaches to biophysical profile and fetal surveillance. So, remember, fetal surveillance is that one chapter which you cannot leave when you are going for any exam. Antepartum fetal surveillance and intrapartum surveillance. You must know the NST, biophysical profile, and the amniotic fluid dynamics very nicely. You should know something about the Doppler, and in addition to this, the intrapartum fetal surveillance, which is to know the cardiotocography. So far, they have not asked you about the fetal scalp blood sampling, but that is something which you should know, that fetal scalp blood sampling during the labor is one good way of assessing whether the fetus is having some acidosis. So, when the cervix is 3-4 centimeters and more dilated, you can make a nick on the head of the baby and take some blood and check the pH of the fetus. Less than 7.2 is acidosis. Right. Which of the following is not cost-effective regular screening procedure advised for pregnant women? I think they gave you one, straight away question so that you get the marks. So, you know that GDM testing is done, and GDM testing, please, I hope you don't know any other variation, but AIIMS people have given this question around 5 years back, and ever since all exams are giving this, and most hospitals are following this, and that is that we do the GDM screening after 24 weeks, and we do the one-step test. You know that very well. It is done with 75 grams of glucose. So, we see the fasting levels and then give 75 grams of glucose and then 1 hour value and the 2 hour value. Fasting should be less than 92, 1 hour should be less than 180, and 2 hours should be less than 153, and any one abnormal value is a diagnosis of GDM. Of course, there is a modification by the DIPSI guidelines, and DIPSI guidelines say that you can do just one test and the patient comes non-fasting, but that has not been asked of you people in the exams. Okay, so GDM is done. Hepatitis B testing is obviously done. We know that hepatitis B doesn't transmit during pregnancy, but mostly it transmits in the peripartum period when she is delivering. And of course, the RPR or the VDRL is done. echo is not at all cost effective as a screening method. If she's symptomatic, she's got any breathing difficulty, she's got a history of heart diseases, rheumatic heart disease. Recently, we had a patient who had tachycardia, which was not attributed to any cause. We did all the investigations and she continued to have a tachycardia of 140, and otherwise she was asymptomatic. Then I said, I'm going to send you to a cardiologist, and she got her echo, and in the echo we found MR, and she was a case of RSD in childhood, which she did not want to disclose in front of her husband, because every time she came to the OPD, the husband was sitting next to her. I'm talking about a private OPD. In my hospital, some patients come and they have the privilege of coming with their wives and discussing in the private kind of setup. And that time when I was discussing with the husband, and she never told us that she had a rheumatic heart disease as a child. So finally, the cardiologist said, yes, there's a lesion, and we found out. So that echo was done only when the patient was symptomatic. So remember, echo can never be a cost-effective screening method for everybody who's getting pregnant. Obviously, we will always do a pap smear in the first trimester. That's a good screening method for CS cervix. We'll examine the breast. All of these screening methods are part of the antenatal care. And whenever you have time, please go through the video which is there on YouTube regarding antenatal care from the Prep Ladder Forum. Okay. So the answer is D. High risk HPV does not cause which of the following? Now, all of us know high risk HPV does cause CS cervix, the 16 and 18. Most common is 16 and most malignant is 18. There are many other serotypes which cause the malignant type of CS cervix, and you know of Gardasil 9, highly virulent type of serotypes which can cause CS cervix, and Gardasil 9 is taking care of those. But yes, these high-risk HPVs can also cause anal carcinoma and oral carcinoma, but they do not cause laryngeal papillomatosis. Of course, laryngeal papillomas are caused by human papillomavirus. There is no doubt about that, but those are 6 and 11, the low-risk types. So that will cause laryngeal papillomatosis, not the high-risk types. That was a straightforward question. All of you, I'm sure, got this one right. Question number 7. What is the mechanism of action of 5-alpha reductase inhibitors like finasteride and duosteroid? There are these drugs which are given in hyperanogenic conditions for women with hirsutism. And what do? They reduce the active form of testosterone, which is the dihydrotestosterone. I don't know whether this was the question or the other question was, what is the result of 5-alpha reductase inhibitors usage? So I've got both the questions for you. One was that what is the mechanism of action of 5-alpha reductase inhibitors? It is dihydrotestosterone blockade. Let's not look at the other choices. And question number, the same question repeated again, just to see the other variation of question which might have come in the exam. And that was what is the result of 5-alpha reductase inhibitors? It increases serum PSA. No, it actually reduces. And testosterone decreases. No, it doesn't have action on testosterone. Dihydrotestosterone reduction. Yes, that is the answer which we are looking at. Reduction of prolactin, no action on that. So yes, 5-alpha reductase inhibitors, they will reduce the dihydrotestosterone, the active form of testosterone. So that is the answer. Question number 7, the answer is C, and in the previous form again the answer is C. Now, testosterone converts to dihydrotestosterone by 5-alpha reductase, and this is inhibited by finasteride. But finasteride, remember, acts on the type 1 5-alpha reductases. So this enzyme has two types of receptors, type 1 and type 2, and finasteride mostly acts on the skin, not on the reproductive tissues. So prevalent in the skin, acts mainly here. This finasteride acts mainly here. But duosteroid, I hope I'm getting the spelling right. I've not used much of this drug, but yes, I've read about it. So that is the one which is having good action on both type 1 and type 2 alpha reductase in, receptors. Okay. Which of the following is related to Kasowitz rule? Now, Kasowitz rule has come second time in 2 years, and all of you know that when there is congenital syphilis affecting a fetus, next pregnancy, the fetus is likely to do better. This is a classical, I'm sure all of your teachers and wherever you've been reading about this, they would have already told you that when a woman loses a child to congenital syphilis, let's say this time she has an abortion, next time she may have a preterm labor and a stillbirth, and third time maybe she'll have a healthy live birth fetus. So that is associated with congenital syphilis. And if a woman with untreated syphilis has series of pregnancies, the likelihood of infection of fetus in later pregnancies becomes less. That is the Kasowitz rule, and that means that syphilis, when present in a untreated pregnant woman, it may lead to a series of miscarriages, preterm deliveries, stillbirth, low birth weight, and finally a normal child, known as the Kasowitz law. Now, I just thought I'll make a slide for you people to have a quick recall of the congenital syphilis. Now, congenital syphilis can present as early congenital syphilis, which is in the first 2 years of life. I think maybe this is in green and you might not see. It's in the first 2 years of life, which has got skin rashes, mucus patches, lymphadenitis, and hepatosplenomegaly. It can come as a late congenital syphilis, which is the time when there is 2 to 30 years of life, and this is mostly asymptomatic and diagnosed by serological testing, and it may have interstitial keratitis, eighth nerve deafness, and Clutton's joints. Yes, I'm sure your medicine people and the derm people have bombarded all of you with this information regularly, but I thought might as well I'll make a slide on that. So, what is stigmata regarding congenital syphilis? Scars, deformities from early or late lesions. So, stigmata of early congenital syphilis is the saddle nose deformity and the Hutchinson's teeth and Ragade's and onychia. And stigmata of late congenital syphilis is perforation of the palate, corneal opacities, and optic atrophy and periosteal tibial changes. So, that's a quick recall of the congenital syphilis. Let's move on and see question number 9. Regarding the pathogenesis of preeclampsia, which of the following is incorrect? Now, this is that one question which I thought was too much in detail. I think, I looked into many other forums where this question was discussed, and unanimously everybody had these choices recalled, and good question actually, but yes, it's pushing the limits a little bit. You have to know things in detail now. So choice A, there's an increase in soluble FMS like tyrosine kinase 1 and a decrease in placental growth factor. Okay, let's see this first. Now, what happens in pregnancy when the placenta starts forming? Around 20 weeks onwards, secondary placentation starts. And what is secondary placentations? The blood vessels in the placenta becomes a little bit dilated, and there's a trophoblastic invasion to replace the smooth muscle, and there are a lot of vasodilator influences which are going to make the perfusion to the placenta better. Now, those vasodilator influences, they start getting corrupted in a patient of preeclampsia, and we can see these factors before the patient presents with preeclampsia. So, that's why we are talking about those angiogenic factors. So, the soluble FMS like tyrosine kinase 1 and a decrease in placental growth factor. What is the meaning of that? Let's see. Now, there is normally overproduction of anti-angiogenic peptides, which I just told you, the SFLT1 and soluble endoglin. What normally happens, let's see, this is normal. In the blood vessel, this is from Williams obstetrics, a modification of that diagram. So, in a normal woman with blood vessels in the placenta, will have this transforming growth factor and the vascular endothelial growth factor, which will bind with receptors, and these transforming growth factors and the vascular endothelial growth factors cause vasodilation, which is good for perfusion in the placenta. Now, what happens in PIH or preeclampsia like we call it? There is this soluble FLT. This will come and inhibit the binding of vascular endothelial growth factor with the receptors on the vessels, and then the endoglin will also prevent the binding of the transforming growth factor to the receptors on the blood vessels. So, these receptors, when they bind to the transforming growth factor and the vascular endothelial growth factor, they cause vasodilation. So, these anti-angiogenic peptides, they come in between and prevent this binding. The net result of that is that there will be vasospasm. When there is vasospasm, the perfusion to the placenta is less. So, I'll just read that for you once again. Elevated meterin SFLT1, these inactivate and reduce the circulating free placental growth factors and VEGF and causing endothelial dysfunction like I described. And the soluble endoglin, this inhibits transforming growth factor binding to the endothelial receptors. So, what I just told you has been written here for your recall. Along with lower platelet growth factor concentration correlates with preeclampsia development after 25 weeks. So that is about the anti-angiogenic peptides. So there is an increase in this and the decrease in this, that is a correct statement. Vasoconstriction leads to ischemia, necrosis, hemorrhage and end organ damage in preeclampsia. We know that very well, isn't it? We know this part of etiology is always discussed with you people in most of your MBBS classes, and we also recall this many times for you, that the trophoblast will come and invade the blood vessels and replace the smooth muscle of the tunica media and cause a dilated vessel. So see here, in a normal pregnancy, the extravillous trophoblasts and the interstitial extravillous trophoblasts, they will come and replace this. There is no smooth muscle. This smooth muscle is taken off. But when this is inadequate, see, the trophoblasts are just here. They are not coming and replacing the smooth muscle in the spiral arteries in this side of the diagram. So when they are not replacing the smooth muscles, there will be vasospasm in the blood vessels. So yes, vasoconstriction leads to ischemia, necrosis, hemorrhage. That's the pathology of preeclampsia. Now, endothelial dysfunction leads to reduced nitric oxide levels also. Now, nitric oxide, all of you know, is a vasodilator. It relaxes the smooth muscle. So nitric oxide is a good vasodilator and it is helpful in maintaining perfusion. Now, if this is also less, that is a correct statement. This is indeed less in a woman who's got preeclampsia. That is also a correct statement. So these three are correct statements. Now choice D, there's a decrease in thromboxane A2 and an increase in the prostacyclin 2 and thromboxane A2 ratio in preeclampsia. Now this is exactly the opposite what happens in eclampsia. So there is an increase in thromboxane A2 and there's a reduction in the prostacyclin and thromboxane A2 ratio. This is what happens in PIH. So this is a wrong statement. So now let me show you this, that patients with PIH have more vascular reactivity to norepinephrine and angiotensin. So more vascular reactivity to angiotensin and norepinephrine. It is because the vasodilator influences like prostacyclin are less. So reduction in endothelin prostacyclin and increase of thromboxane A2 by the platelets, and hence prostacyclin and thromboxane ratio declines in a case of preeclampsia. So yes, that is what is a wrong statement in this. Okay, it does not increase, it reduces the ratio. Okay, so in gist, the culmination of this discussion of the etiology, vascular endothelial growth factor, plasma growth factor reduces, and the SFLT1 endoglin increases, nitric oxide reduces, and of course the prostacyclin thromboxane A2 ratio reduces. So all of that is the etiology there. Now question number 10. Which of the following is incorrect statement regarding magnesium sulfate used in preeclampsia? Now magnesium sulfate, whatever happens, magnesium sulfate has to be read, and the most common regime which we give is the Pritchard's regime. Pritchard's regime is the one which is IV loading along with the intramuscular loading of 14 grams, not milligrams. So 14 grams is the loading dose of magnesium sulfate. Along with that, we give 5 grams intramuscularly every 4 hourly, seeing the respiratory rate, urinary output and the knee jerks. So when we see all of this, that's how we give the magnesium sulfate. Please remember, read about MaxSelf always before the exams. So MaxSelf should be given for 24 hours after a convulsion. Yes, correct. It should also be given 24 hours after the delivery also. So we say once a woman is delivered, she has, suppose she's thrown a convulsion, we plan a delivery for the best treatment. Delivery is the best management. So we do a delivery. After delivery, suppose she delivers 8 p.m. tonight, we must give the MaxSelf till 8 p.m. tomorrow night. But yes, tomorrow 8 p.m. if she throws another convulsion, then we must give it till 8 p.m. day after tomorrow. So that's what is the meaning of this statement. MaxSelf in renal failure loading dose can be given, but maintenance dose should be adjusted based on renal function, correct? And MaxSelf covers seizures and hypertension simultaneously. Now that's a wrong statement. MaxSelf is the only neuroprotective drug given in preterm labor. I think that information was just given as a choice which somebody could not recall, and yes, it's a neuroprotective drug, but that's in preterm labor discussion. Never mind, choice C is definitely not correct. MaxSelf covers seizures, yes, but it does not reduce the blood pressure. So remember one thing, every time in the exams when I ask you what is the drug of choice for convulsion, you say MaxSelf. then what else you do? Some of you may go ahead and say, yes sir, we'll do a delivery because that's the most definitive management of eclampsia. Delivery will cure the woman fastest. But all of you forget to say, give IV labetalol. Now that is what is going to reduce the blood pressure. Yes, if I ask you what is the drug of choice for hypertensive emergencies in pregnancy, unanimously everybody says IV labetalol. Now, if I ask you the question the other way around, that in a case of eclampsia, what all do? You will say Maxell. Some of you may say delivery, but then after that you stop. Labetalol, IV labetalol is given for the control of the blood pressure. All right, let's move on. Question number 11, maximum dose of labetalol in 24 hours in a pregnant woman is drug of choice for hypertension in pregnancy is labetalol, and it is also the drug of choice for chronic hypertension in pregnancy. Please remember, labetalol, methyl-dopa, hydralazine are all first-line drugs, but the safety profile of labetalol is even better than hydralazine and methyl-dopa, and it's very effective. That's why it is now purported to be the drug of choice. Recently in the MCA exam, around 6 months back, they did not give labetalol as a choice. They gave methyl-dopa as the most obvious answer. So yes, do not forget that methyl-dopa and hydralazine also can be asked. So whenever you're reading about the drugs in hypertension in pregnancy, read the pharmacology of all these three drugs. And labetalol is alpha and a beta blocker. And I have given up to 2400 milligrams of dose. So that is the answer which is correct. And I think these were the choices. But if you want to really consult a book, then the answer is actually 1200 milligrams. So be a little careful, look at the choices, because the correct answer, if it was in the choices, is 1200, all right, because Fernando Arias books categorically says 1200 milligram max dose in 24 hours, but none of you gave me that choice. So yes, because most of us say that we can give up to 2400 milligrams in 24 hours. So that is the oral dose. So orally we can give around 1200 milligrams in 24 hours, and intravenous, that is, suppose a patient comes in a hypertensive emergency and the blood pressure has to be controlled, then we give it IV 20 milligrams, and then we give another 20 milligrams after 10 minutes, which is not controlled. Then we increase it to 40, and we can also increase up to 80 milligrams to get the blood pressure under control. So IV labetalol, how much you can give maximum to reduce the blood pressure, that's a different question. IV is 220 milligrams and oral maximum is 1200 milligrams. But since that was not the choice which was recalled, so I'm marking 2400, which is practically given by a lot of us in the clinical life. And I think that was the reason why this was given as choices. But only one book gives the values which you, one authentic book which gives you the values is this Fernando Arias textbook, and gives 1200 milligrams in 24 hours as the maximum dose. Okay, so question number 12. All of the following statements are true regarding the Manning score, except Manning score includes breathing movements and fetal movements and the tone, fetal heart rate, amniotic fluid volume. Yes, it includes all of this. You know, the fetal heart rate accelerations by NST, that is correct. So fetal breathing, fetal movement, fetal tone, fetal heart rate accelerations by the non-stress test, and the amniotic fluid index. Yes, all these 5 are there. Each one of these is given 2 marks, and 10 out of 10 is a perfect biophysical profile. That's correct. Can tell us about fetal outcome and fetal pH? Yes, it does. That's why it is a test for fetal surveillance. Yes, we've been discussing about that, isn't it? Score less than 4 is consistent with the fetal pH of 7.2, and score less than 2 is predictive of fetal acidemia. More or less a correct statement. The lesser the biophysical profile, more is the chance of poor fetal outcome. I would mark this correct. Score is consistent with fetal pH at different gestation ages. Now, this is not very easy to swallow here, because it is not that definitive, because sometimes we have values of, let's say, 6, and it could be a bad fetus or it could be a fetus who might do well after another day of observation. So, you know, you cannot say that it is consistent for every gestational age. You don't have values which correlate very strongly with the outcome of the fetus. We don't have such values with biophysical profile. So, we have to have your own clinical judgment along with the biophysical profile. So, choice D doesn't make much strong correlation with the truth. So, I will say that is the wrong statement here. So, biophysical profile, 10 is good, normal non-asphyxiated fetus. 8 by 10 is also all right, because 8 by 10, I will take that score if the amniotic fluid volume is good. If the amniotic fluid volume is good and suppose the NST is not reactive, 8 by 10 is not a very bad score and the baby is non-asphyxiated. I can repeat the NST after some time, or whatever else is not good, we can repeat it after some time. So 10 and 8 by 10 is fine. Now 8 by 10 with low FI, that is a chronic fetal hypoxia. 6 and 4 possible fetal hypoxia, but 2 and lesser certain fetal hypoxia. All right. Now, when there is a patient with 6, we have to start using our clinical judgment and start associating AFI with this finding. If the AFI is good, then probably you can repeat after some time and see if the score is somewhat better. If the AFI is less than what you want, if the AFI is less, then you may want to deliver when the score is 6. So, when the score is 6 and 4, a lot of clinical judgment comes into discussion. Less than 2 definitely is acidosis, and more than 8 by 10 is mostly a good biophysical profile. Now, question number 13. Regarding postpartum hemorrhage, which of the following statement is incorrect? Loss of more than 500 ml of blood in vaginal delivery. Yes, that is the easiest part of the PPH discussion. 500 in normal delivery and 1000 in cesarean delivery. Initial replacement by colloids, 4 times the amount of blood lost. If this was the choice, see, we do give colloids, isn't it? A lot of us say get Himaxal, get starch, we keep saying that, gel fusion leke aao, all that we keep saying in the labor rooms. But yes, all the time remember what is running has now to be increased in the flow rate. So yes, a normal saline or a dextrose normal saline is running, that we increase in flow rate. So always instantaneously and subconsciously, what you do in a labor room, you increase the crystalloids. Yes, you arrange for the colloids. So that's what is asked here. How much time as interns you spend in the labor room? So yes, I would want you to say not colloids but crystalloids. So maybe this is not the correct statement here, and also depends on the way you people have recalled the choices here. Chorioamnionitis, multiple pregnancy and prolonged labor are the risk factors. Correct. So these two are correct statements. Adding 500 ml for each 3% drop in hematocrit, the volume of blood loss can be calculated. Now, this is a simple statement, but then we must understand what they're trying to say here. So, what is the blood volume in a pregnant woman and what is the blood volume in a non-pregnant woman? So, one rough estimate of blood, just multiply the weight of the lady by 100. Suppose she's a 60 kg woman, her blood volume will be 6 liters. That's one way to find out the volume of a pregnant woman. Now, let's go into more strict calculations. Non-pregnant blood volume is 50 into height in inches, 25 into weight in pounds divided by 2. So, that is the non-pregnant volume. Now, how much does a woman add in pregnancy? 50% she adds in pregnancy. So, if we see this closely, suppose the volume of woman is 6000 ml and she adds something like 3000 ml in pregnancy, because that's what is written, isn't it? 50% increase. Suppose a woman had 6 liters, now there is 50% increase in the volume, so that should be 3000 ml. So that could be there in a woman who is a well-built lady who's got 6 liters, now she's added 3000 ml with her pregnancy. So what are the things to look at when there is PPH? If blood loss is less than the pregnancy added volume, the hematocrit remains the same. Obviously, whatever has increased now goes out with PPH. So there's no loss to the mother's basic hematocrit. Whatever she gained in pregnancy, she lost in delivery, the hematocrit will be unchanged. Now, if post-delivery the hematocrit is lower than the hematocrit before delivery, okay, now suppose she comes to us in the labor room with a hematocrit, let's say, of 36. Hematocrit normally can be 36 to 42 in a lady. So let's see 36, which is equivalent to around 12 grams of hemoglobin. So hematocrit is 36, equivalent to 12 grams of hemoglobin. Now, when she delivers, after that, the hematocrit actually falls. Then what is the calculation? So post-delivery hematocrit is lower than the hematocrit before delivery, then the blood loss can be estimated as, suppose it has become 33, from 36 it's become to 33, the hematocrit. Before the delivery was 36, now after delivery she's lost a lot of blood, and it should not be, the hematocrit should not come less than 36, because whatever was gained has now been lost in labor, so hematocrit should be 36. Now there is even more than that loss. That is, the hematocrit has gone below 36. So if post-delivery hematocrit is lower than the hematocrit before delivery, then the blood loss can be estimated as the sum of calculated pregnancy added volume, sum of calculated pregnancy added volume. See, pregnancy added volume is 3000 plus 500 ml for each 3 volume percent decline. So it is not a complicated statement. Hematocrit is in percentage. So when the hematocrit from 36 drops to 33, for each 3 volume percent, that is for each 3% loss, that is 36, say it has come down to 33, there is a 3% loss. For every 3% loss, 500 ml of blood loss is also added. That means now if a woman has a hematocrit of 36 when she was pregnant, she delivers, the hematocrit is now 33. So she's lost how much? The added blood she has lost. So 3000 loss is definitely there, because after delivery, hemoglobin and the hematocrit should be the pre-pregnant level easily. So now the woman is 36, she loses blood, she comes to 36, all right, whatever she's gained, she's lost. Now from 36, she's come down to 33, that means more blood loss than what she had gained. She is lost from her reserves. What she gained, she lost, she should have come back to 36. Now there's more loss, that means from 36 she's come down to 33. So for every 3% loss, 500 ml blood would have been lost in labor. So if it has come from 36 to 33, another 500 ml loss. So this woman, when the hematocrit comes down from 36 to 33, it is 3000 the gained volume plus 500 ml for that 3% loss. So that's how you calculate, and such a complicated statement was given here as the choice 4, choice D, that is. So yes, that is also a correct statement. I tried to make sense of that by telling you how the volume is gained and how it is lost. Remember one very basic principle, that hematocrit basically divided by 3 is the hemoglobin. So for every gram lost, it is 500 ml. So simple. Just that they've given hematocrit as the criteria of discussion here, and we got so worked up. Once again, hematocrit divided by 3 is the hemoglobin. If you remember this basic principle, so if she loses 3% of hematocrit, there is 500 ml of blood loss, which also means that if she loses 1 gram percent of hemoglobin, that is from hemoglobin from 12 goes to 11, that is 500 ml of blood loss, means the same. Which also means what I have been teaching you always, 500 ml of blood loss is PPH. Also, any woman losing 1 gram of hemoglobin in delivery is also known as PPH. That's the other definition of PPH. It all comes back to that. So just the same thing has been discussed in many different ways to make life complicated, but it is just as simple as that. Okay. Question number 13. Regarding management of diabetic women in labor, which of the following is incorrect? Elective cesarean section has no effects in reducing the incidence of brachial plexus injury, and that is a correct statement. So we have to tell the incorrect statement. This is a correct statement. Please see, when you do a delivery of a fetus, I'll show you a cesarean section here. We are just opening up an abdomen here. I'm putting the Doyens has already been put. Yes, I've got the bladder retracted, and I'm going to just open the lower segment now. But remember, whenever the baby comes out in a normal vaginal delivery and in a cesarean delivery, you know, when the head comes out, we hold the head and then we do this so that the anterior shoulder comes out. So the same also happens when we're doing a cesarean delivery. Suppose the baby is big, then the same traction, when the head comes out, the same traction is applied on the shoulders again. See, now I've made an incision here. I'm extending incision, the liquor has come out. Now I've put my hand inside to take out the fetus. Now you will see how the shoulders come out even in a cesarean. I'm sure you've seen cesareans very closely yourself. Now see the anterior shoulder coming out. So that, see, I have to turn to take out the anterior shoulder, and if the baby is big, that big baby may have a brachial plexus even here. If the baby is 4.5 kgs and I've done a cesarean, so take that big baby out of this incision, there will be traction again on the brachial plexus. So it is no guarantee that if you do a cesarean, then you're going to reduce the brachial plexus injuries. Right. Always fun to do a cesarean any time of my life. The happiest in the labor room I am. Okay. Question number 13. Choice A is correct. GDM patient should be given the morning insulin at the time of induction of labor as usual. This is one statement I'm not very happy with. There's a lot of variation to this, but the basic set rules you should know. Now, that means you must know how to manage insulin administration of a woman who is getting into the labor room. Again, depends on how many hours as an intern you spend in the labor room. So, yes, the cardinal rule is that please give the night insulin, and the morning insulin is never given. What we do, we give a infusion of insulin with IV if required. We're given a neutralizing drip most of the time, and we all know that we may need more insulin than normal when the patient is going to labor, because stress will increase the demand of insulin. So we can never manage by the the regular dose which is given. So we'll have to see as the demand of insulin increases or decreases. So yes, patient should be given the morning insulin. No, we are omitting the morning insulin. So this is the incorrect statement. Yes, this is not correct. So answer to this question is B. Regular insulin is given by infusion pump. Yes, just now we discussed. Capillary blood glucose levels are maintained approximately 100 milligrams per deciliter. And this question has a lot of reminding for me as a typical JIPMER question, and a lot of questions from JIPMER entrance used to come from lines from Williams Obstetrics. I'm very sure that everybody is contributing to make this question paper here. So yes, this has some amount of relation to the JIPMER style of questions. Anyway, insulin management during labor and delivery. Usual dose of intermediate acting insulin is given at bedtime. Morning dose is withheld. Intravenous infusion of normal saline is begun, and once active labor begins, so glucose level decreased to less than 70, the infusion is changed from saline to 5% dextrose and given at the rate of 100 to 150. Now, the glucose level of approximately 100 milligram per deciliter is maintained. So, this is what was given in the choices here. Glucose levels are checked hourly using a bedside meter, allowing for adjustment in insulin or glucose infusion. So, hourly bedside glucose, and regular short acting insulin is administered by intravenous infusion at a rate of 1.25 units per hour if glucose exceeds 100. So, try to keep it around 100, that is a correct statement. So, we got that, keep it around 100 and give the insulin by a pump, and we do not have to give the morning dose of insulin. That was the answer to this question. Now, I don't know what were the choices for this question, so I've just taken this question and trying to give you the answer straight away. Human papillomavirus vaccine dose, for 9 to 14 years group according to the WHO SAGE criteria is. Now, the strategic advisory group of experts on immunization, the SAGE group, which associates itself with WHO, it says that one dose is enough. But yes, what is ideal? We should give 2 doses, we know that. In fact, 3 doses also given of Gardasil. But what is good enough and very difficult to give immunization to everybody across the world? So, we say 9 to 14 and then again 15 to 20, at least give 1 dose. So, 1 dose will give enough protection. Yes, best to give 2. So, 1 or 2 scheduled for the primary target women 9 to 14 years, 1 or 2 dose scheduled for young women 15 to 20 years, and 2 doses scheduled for women who are older than 21. Now, that is the immunization schedule, and at least 1 dose should be given. Now, is 1 enough? Yes, 1 is enough, although ideal is 2 and more. Now, what I wanted to tell you here was that this one, the FDA extended the recommended age indication for Gardasil 9 to include men and women aged 9 to 45. So, now this is the part which is getting a little interesting, that you must give human papillomavirus vaccine Gardasil 9 not just to women but also to men. So, all boys and girls should have the HPV vaccine. So, in effect, the whole population should have the vaccine. Now, that's where it is getting very interesting, because The efficacy of the vaccine is 90% against 9 serotypes, the ones which cause the malignant type of C. cervix, the 9 very important ones. But there are more than 50 serotypes. So yes, 40 and more serotypes are not covered by this vaccine. But still you must give it to everybody, boys and girls. So imagine the kind of business which is at stake when such an expensive vaccine is given to everybody. So there's a lot of discussion about the vaccine and the efficacy and how good it is that you must give the vaccine to all boys and all girls across the continents. So the commerce is mind-boggling. So that's why I always say read a little bit more about these vaccines. Yes, the questions do keep coming about this, and they keep asking you what is the dosage of Gardasil 9, and you must give at least one dose, ideally is 2 and more. You must give it to boys and girls. That part you know, but how effective it is, you must keep an eye on that also. Yes, basic principle is something's better than nothing. So that way, if you look at things, then go ahead and give it, but don't blindly bank on the vaccine, because it's going to prevent only against these 9 serotypes. 90% if given before exposure, 40% if given after exposure. That's the effectiveness of these vaccines. Okay, so do read about the vaccines a little bit more and don't blindly bank on the vaccine. So what should you be idly banking upon? Yes, tell your patients to have a good, safe sex life. That is what is going to work even better. But who's going to listen about that? That is what is the major problem. To have a clean and safe sex life is virtually a good guarantee against C. cervix, but not many people are going to follow that. So something is better than nothing is the bottom line of the discussion I tried to have just now, and give the vaccine for some benefit at least. Okay, question number 14. A woman after breast removal surgery for a C. cervix probably received tamoxifen. How long pregnancy should be delayed? That is a breast cancer survivor. A breast cancer survivor, when she can plan a pregnancy. Okay, now there should be a definitive gap of 2-3 years, we feel, because pregnancy is going to increase the hormones, and CA breast is a hormone dependent cancer. So at least wait for 2-3 years after CA breast treatment for planning a pregnancy. That is straightforward. But now they've asked specific regarding tamoxifen. Now tamoxifen, you know, can cause congenital anomalies if given in pregnancy. So we say wait at least 2 months. Now the choice which is closest to that is 3 months here. I mean, of course, 1 is also close, but I would want to go near 3. So at least 2 months we should wait according to Williams Obstetrics. So 3 is the choice which I would mark here. So women treated for breast cancer, recurrence is a concern, reasonable delay is at least 2 to 3 years, and hormonal contraceptive methods are contraindicated, and a copper containing intrauterine device is the best option for women who is on a follow-up of CA breast. Now women treated with tamoxifen are risk for several months after its discontinuation to have congenital anomalies, so wait at least 2 months. That's what we discussed just now. Question number 15. From adluminal to luminal, arrange the following series of events in spermatogenesis. Basically, they just want to trouble you now. All of you know this question very well, that from the from the beginning of spermatogenesis to the end, what are the stages? That question has been coming so many times in exams. But now they're asking you a question that from adluminal, that is from the edge of the seminiferous tubule to the lumen of the seminiferous tubule, what are the stages of spermatogenesis? It's just the same question asked in a different manner. So yes, from the myoepithelial cells, this formation of the spermatogonia, then there is a primary spermatocyte, and then there is the secondary spermatocyte, and after that is the spermatid, which further becomes the spermatozoa. So for me, the chain of events which I want to answer would be A, B, C, E and D. That is the chain of events. So the choice would be choice A. That is the answer to this question. Now we can see that in this picture that spermatogenesis, you know, it starts from the spermatogonium here, spermatogonium, and then it makes the primary spermatocyte, and then after the first meiotic division, it makes the secondary spermatocyte. The secondary spermatocyte has a haploid number. It is haploid. Primary spermatocyte is diploid. That used to be a question long back for you. Now secondary spermatocyte becomes the spermatid then, and the spermatid becomes the mature sperm. So from the, you can see in this picture that from the adluminal to the lumen. So, those are the chain of events. Okay. Question number 16. A 37-year-old unmarried female whose mother has CA breast at 50 years of age and sister had a cancer at 40 years of age comes for a regular checkup. She is sexually active and taking oral contraceptive pills for contraception. What would you advise as the next step? Please don't stop the combined pill. Combined pill reduces benign breast diseases, but it does not cause CA breast. Now, that is where all of us are getting it a little wrong. Please remember, Williams Obstetrics says is very categorically that there is no significant increase with the use of combined pill. That's the latest Williams 25th edition. OCPs, yes, they do not prevent CA breast, but they do not cause also CA breast. So, the incidence of CA breast with combined pill is unchanged. A stronger answer would be do a genetic counseling for BRCA antigens. So, do that. If that is present, then you may have to do more further screening and look for lesions, and you may have to do prophylactic surgery, but first thing is to do a genetic counseling. So, definitely not the answer to stop the OC pills. Okay, genetic counseling is correct. Mammography at 37 won't show a good mammography is effective in picking up lesions only after 40 years. All right, so answer is C. Question number 17. Which of the following cervical cerclage procedures should be done in a non-pregnant female with cervical incompetence? Now, a cervix less than 2.5 centimeters is an incompetent cervix, and we must be doing a cerclage for that. And the most common cerclage, all of you know, in pregnancy is the McDonald cerclage, but that's not the question they're asking you anymore. They've asked you the cerclage for a non-pregnant lady. That also means that I have to teach you much more now when I meet you for the classes. So, there are many cerclage procedures, and some of them are put in a non-pregnant female when the cervix are very short and mutilated cervixes, the ones in which you cannot put a stitch when you try to do in a pregnancy because it's hardly any cervix in the vagina. So, yes, let me go step by step here. Classically, we do a McDonald suture, that is the cervix is, suppose I show you end on cervix like this, and the suture goes like this. So, that is how we do the suture of the McDonald's. Now, Shirodkar is for a very short cervix. So, McDonald is done vaginally, Shirodkar is also done vaginally, but it is for the very short cervix. Now, you must try and understand the Shirodkar a little bit since you are trying to do a PG entrance preparation here. Now, the cervix is very short. See here, cervix is very short, and this is the bladder in front here, and this is the rectum here. I am showing you the sagittal section. Now, if the cervix is short, now that's the difference. If the cervix is short and very short, that is what is the difference. If the cervix is short, the same McDonald stitch can be applied very easily here. The cervix is short, but it is around 2 centimeters, 1.5 centimeters. I can put a stitch from the vagina. So, the McDonald stitch looks like this in a sagittal view from the right side. Now, the same cervix is so short here that I cannot, look here, the vagina is here, hardly any place for me to sit the suture. So, what do? I will have to remove this vaginal wall from here and from the back here, dissect the vaginal flaps, and then put a stitch here, and then put the vagina back here. So, we have to do a vaginal dissection and then reach the part of the cervix which is above this vagina and put a stitch. So, Shirodkar stitch requires a lot of good surgical acumen, can be done in a pregnant lady. Now, what are the other stitches? The stitches which are applied at the isthmic area, we call them the cervico-isthmic encerclage or cerclage. They are for the extremely short or lacerated or amputated cervix for a, let's say, for a conization, and you think that in a pregnancy it will be very difficult for you to do. So, these are also known as the AK, also known as Benson and Durfee, can be done in a pregnant woman originally, but can be also done in a non-pregnant woman. So, Benson and Durfee is a procedure which can be done vaginally, requires a lot of dissection. So, we used to do it abdominally, abdominal cervico-isthmic cerclages. Abdominal placement of a cerclage. I have done only one in my life because most of the times vaginal surgeons are able to do all things vaginally. But yes, that is cervicoisthmic cerclage. Now, transcervical procedure, lash procedure, lash and lash like we call it, okay, transcervical procedure, the lash and lash. A traumatized cervix with laceration visible in the non-pregnant state. The cervix is so short, it is traumatized, it's in bits and pieces, and that kind of cervix you cannot sit any suture. So what we do the procedure in a non-pregnant woman because the bleeding will be much lesser. It will be easier to put the stitch, and we mostly go transabdominally. And another type of cerclage is the Mann cerclage or the page wrapping technique. All of these are done in the pre-pregnant state. Now, lash and lash is not really done so much now, but I don't know whether they wanted to just test that. You're reading some other books beyond the regular notebooks, which are whether the regular standard textbooks which are advised in the curriculum. They just wanted to test that, and it's really a little difficult for you to remember all these procedures. But yes, lash and lash was the answer here. So Benson Durfee is also one of the procedures, but it used to be classically done for pregnant women. So I will say it can be done in non-pregnant, but I would say that it is not a strong answer as lash and lash. Worm cerclage, yes, worm cerclage. We go through the os like that. That's a worm stitch. McDonald stitches all around. Worms is through the cervical canal. All right. So question number 18, which of the following drugs is contraindicated in a pregnant patient with psychiatric disorders? Now, I don't know whether it was mania as the choice in your questions, but psychiatric disorders, whatever drug you give, we never give lithium because lithium is a category X drug. Yes, we know sodium valproate is a category D drug and carbamazepine is a category D drug, and carbamazepine is given even as of now. You know, oxcarbamazepine is given to so many patients I see in my OPD. The neurologists trust that, and yes, the benefit of the drug exceeds the risks, which are limited risks. So benefit of the drugs exceeds the risk from these drugs, the category D drugs. So we give category D drugs in pregnancy. So carbamazepine is given, but even better than carbamazepine are the category C drugs like levetiracetam and lamotrigine. But that is not for psychiatric disorders. These are for epilepsy. So that's why I think the choices were somewhat different from what you people have given me here. I would straight away go and say that lithium is the answer. Question number 18, this is not given at all because lithium is known to cause the Epstein anomaly. You people know that much better than me. So question number 18, answer is C. What is the half-life of letrozole? Now letrozole half-life is, remember one thing, now letrozole is that drug which is given first for ovulation induction when a woman is having anovulation. It is that drug of choice now. Ever since 2018, clomfene citrate has been replaced by letrozole because it got far more benefits, because it's good on the endometrium. The letrozole, clomfene citrate may cause the endometrium to be a little thin. Letrozole gives a better endometrium. It has less incidence of anomalies if a patient gets pregnant on letrozole, and yes, the patient has much less incidence of twins. Clomfene citrate, almost 8 to 10% of twins are there. It's not that people like twins, but sometimes people don't want to have twins because they are happy with one child, and taking care of two children is always more difficult. So that's why letrozole is now the drug of choice, and the half-life is, yes, it's 48 hours. Okay, half-life is 48 hours. So yes, all of you know that letrozole, which is cleared by the liver, has a short half-life of 48 hours as compared to clomfene citrate, which is 2 weeks. And side effect with letrozole is dizziness and fatigue. Now clomfene citrate has far more side effects. It has got vasomotor flushing, mood swings, breast tenderness, pelvic discomfort, and visual abnormalities, visual scotomas. That is that one reason because of which we will discontinue the use of clomfene citrate. So all of you know that the hypothalamus stimulates the pituitary by GnRH, and pituitary makes the FSH to make the follicle grow, like in blue here, and that follicle will make estrogen to make the endometrium proliferate, and then the high estrogen gives a feedback to the brain to tell the brain to send the LH, and the LH will rupture the follicle, which makes this corpus luteum, the yellow body here, and that will make progesterons, and the progesterone will act on the uterus to make the endometrium secretory. Now, clomfene citrate inhibits the feedback of this estrogen. This feedback is inhibited by clomfene citrate. So the brain thinks that there is no estrogen, and to make more estrogen, brain increases the stimulation to the pituitary to increase the FSH. So clomiphene citrate increases the FSH by blocking the hypothalamic estrogen receptors only. Please, clomiphene citrate blocks only the hypothalamic estrogen receptors, not of the pituitary and not of the periphery. Please, that is also an MCQ. Now, letrozole has a action of reducing the conversion of androgens to estrogens by inhibiting the aromatase enzyme. So when the estradiol production is reduced, again the same information goes to the brain that there is no estrogen in the body. So to increase the estrogen, the brain again increases the FSH. So both of these drugs, whether it's clomiphene citrate or letrozole, works by increasing the FSH in the brain from the pituitary. So the FSH which increases from the pituitary will make a better stimulation of the ovary to make better follicles. So clomiphene citrate reduces the hypothalamic estrogen receptors sensitivity to estrogen. So the brain thinks there is no estrogen, and letrozole inhibits the production of estrogen. So ultimately there is less feedback of estrogen to the brain. Either way, the FSH increases. Right. So the drug of choice now is letrozole. Now, letrozole versus clomiphene. Live birth rates are better, lesser multiple pregnancies, better endometrium because there's better flow and better cervical mucus, and lesser abortions because it's in green, I'm writing it here, and lesser ovarian hyperstimulation syndrome. Now, that's also important because we must remember that what is the most common reason for ovarian hyperstimulation syndrome? That is clomiphene citrate. Yes, clomiphene citrate does not cause the worst type of, the severe type of ovarian hyperstimulation syndrome. That is caused by injections of FSH and HMG. But clomiphene citrate is the most common cause of ovarian hyperstimulation. Now, that is also prevented when we start using more and more of letrozole. So, letrozole and clomiphene citrate both are given from the day 2 to day 6 of the menstrual cycle. So, day 2 to day 6 there is net increase in FSH. So, that is the time when the FSH is high in a normal menstrual cycle. Also, high FSH in this time will recruit the follicles and one follicle will become dominant. So, when I give clomiphene citrate and letrozole, I give in the same time so that the FSH increases during the first few days of the menstrual cycle and recruit the follicles. All right, so those were the questions which were recalled and given to me, and I'm sure you have many other questions you want to discuss. So if you are seeing this on the YouTube, please see the chat below and you can send in your comments, and I'll try and respond to the questions which were left and we can discuss. And those who are seeing this on the app, you always have my email and the Prep Ladder Forum to come back and discuss things with me. All the best with the results, and may God bless you. Thank you so much.